Hello everyone, myself Dr. Samir, and today I am going to discuss about the normal physiology of our arterial blood pressure regulation. So I am going to talk about only the arterial part, okay? So the downstream flow of blood from the heart to the organs and how the perfusion takes place, and we're talking about that. So coming to the starting point, that is our left ventricle. As we know, the stroke volume, that is the volume of blood that is pumped in each beat. So that is pumped against the high resistance which is provided by the peripheral arterioles. So those are the arterioles are our and the venous capacitance vessels. So that resistance that they create, so against that the heart pumps the stroke volume. So the organ blood flow, how much of blood from the stroke volume goes to each organ, is defined by the tone of the precapillary arterioles. So the most of the perfusion or gas exchange takes place from the capillaries. So there are the arterioles, then the capillaries, and then the venules. So the venules or the post-capillary venous system, that is the capacitance vessels, they hold the maximum of the volume of the blood. But the gas exchange or the metabolic demands is met of the organs is met by the your blood flow in the organ in the capillary network. So that depends on the tone of the arteriole, precapillary arteriole. Okay, so the tone is inversely proportional to the flow. So if the flow is high, so the tone will be lower. Okay, and if the flow is low, the tone is higher. So that is auto-regulated to maintain a metabolic activity. So suppose there is a low flow into the organ. So what happens? So the tone of the your precapillary arteriole is reduced. So that causes vasodilation and more of blood flows into the organ. This signaling is done by nitric oxide or endothelium derived vasodilators. This is actually called as the autoregulation. So this autoregulation blunting generally takes place in sepsis or stress or adrenal insufficiency or ICP. So that is why we have organ failure in these conditions. So in ICP we have the blood flow to the brain is disrupted. In sepsis, the different organs like kidneys, livers, they get affected. So stress, adrenal insufficiency, the hormones that they secrete, so they also control. So this autoregulation blunting, this all takes place during these organs, and there is hypersensitivity of your autoregulation in case of essential hypertension when your normal blood pressures are higher than the autoregulating mechanism. We'll discuss that later. So blood pressure autoregulation and its relation to organ blood flow. So the autoregulation is the central BP controlling process, and this can be short term, intermediate term, and long term. For example, our BP shoots up very high. So what are the immediate mechanisms that act to bring it down? What are the intermediate and the long term? Okay, so suppose the BP falls down very low as in septic shock. So what are the short term measures that act? What are the intermediate terms? And there are the long term measures. So let us see how the body copes to it. So the body controls central blood pressure to match demands depending upon the activity or the rest. Suppose the organ is at rest, low blood flow is required, and suppose the activity of the organ is higher, more of the blood flow is required. So there are many short-term, intermediate-term, and long-term autoregulatory processes. So what concerns the intensivist most is your short-term measures. So coming to the short-term measures that take place for the autoregulation of the blood to the organs, it is local ischemia, baroreceptor feedback, or chemoreceptor feedback. Let's see them one by one. So as the metabolic need of an organ increases, so there is before the arteriolar tone changing, there is increase in global sympathetic tone and increase of the venomotor tone. Okay, so that is to increase the trans pressure from arterial to the venous side. So the venomotor tone is increased so that the organ perfusion takes place. The back pressure, critical pressure, we will discuss that again later. So these effects take place without changes in the arterial tone or BP. Once this goes out of hand, then comes the changes in the arterial tone. So the first factor is your local ischemia. So in local ischemia, there is reduced local arterial tone in the ischemic tissue, which can be explained by your vasodilator therapy or lack of oxygen therapy. Now the vasodilator therapy, the theory is that so there is reduction in oxygen availability as the blood flow goes down. that causes your tissue ischemia, and this tissue ischemia causes more production of lactic acid and local adenosine release. That causes your vasodilation. The vasodilation again will cause more increased blood flow. So now coming to the lack of oxygen therapy. So the lack of oxygen therapy leads, there is a lack of oxygen, the endothelial receptors, they sense the lack of oxygen, so there is retrograde endothelial signaling via thymine, or like in beriberi, or in riboflavin or fatty acids or glucose, reduced delivery of glucose to the tissues, reduced fatty acids, reduced thymine, reduced riboflavin, whatever may be the signal. So there is retrograde endothelial signaling via these metabolites. So the feeding arterioles, so because of the feedback mechanism, the feeding arterioles dilate, so there is more amount of blood flow to the organ. So this is the lack of oxygen therapy. Now there is another mechanism called the nitric oxide mechanism apart from these two. So that is what upstream vasodilation once the local flow is increased. Okay, so increased flow, because of the more of the flow, there is more of shear pressure, shear stress on the your capillary network. This capillary network, on because of the shear stress, they cause release of nitric oxide. So this nitric oxide then causes your vasodilation. Okay, so other substrates like your calcium, magnesium, acidosis, like hydrogen ion, carbon dioxide or acetate, they also cause your release of nitric oxide, and that causes upstream vasodilation, which causes more of the blood flow to the organs. So this is your autoregulation. Now coming to the, especially in renal and skin, now blood flow in these organs is up and above the metabolic need, because what happens in the renal system of the kidneys is that they also act as a filtering mechanism of our blood. So suppose a patient is given a 500 ml of bolus fluid. Now that doesn't cause a rise in BP in normal patients. Okay, hypovolemic patients, high cardiac output patients, like in case of sepsis or septic shock, their BP may rise because of the if the fluid bolus of 500 ml is given. But in a normal patient, we generally don't see rise in BP when a 500 ml bolus of any fluid is given. And why? What happens? So what happens is that the blood flow in these organs is up and above the metabolic need. So once more amount of fluid is given, the renal mechanism is to, autoregulation is to increase the pressure in the kidneys. That causes more of the filtration and more of the urination takes place to reduce the volume that has been given to the normal patient. So this is dependent on the arterial pressure. Okay, so what happens, the local mechanism there, it causes more of the filtration and the blood flow is increased, local blood flow is increased. So whenever you measure the oxygen concentration of the renal parameters after giving a fluid boluses, the like SCVO2, the renal venous oxygen will be higher than the SCVO2. Why? Because more of flow is there and it gets ultrafiltrated. Okay, so now hypertension and skin is what happened, the more its activity is to maintain the core temperature of the body. So whenever there is an blood flow increases, it causes vasodilation to suppose there is a patient is in shock, septic shock, so there is vasodilation, there is fever or whatever. To maintain the need, it accordingly causes vasodilation or vasoconstriction. So there is the blood flow in the skin and kidneys generally up and above the metabolic need. Okay, so that is dependent on your arterial pressure. So if the arterial pressure is low, there will be reduced perfusion, there will be reduced urine output, or there will be hypothermia, and so hypotension causes marked reduced blood flow in these organs. Now this autoregulation that the body generally regulates, that thrives above a certain limit. Here the certain limit means the lower, means like if the BP goes down to, say, suppose a map of 50 or map of 40, your 50 suppose of 40, the map autoregulation brings it back to your normal map that maintains organ perfusion. Now if the BP goes down to 20 and 30, the body autoregulation mechanism will fail. So it thrives only above a certain limit. Now if arterial BP falls below that level that allows autoregulation, there will be hypoperfusion. That is where the autoregulation fails. So that will lead to hypoperfusion, tissue death and organ failure. Now the systemic vasomotor control. So systemic vasomotor control is generally under the CNS. How we will see, you know, the sympathetic and parasympathetic. Yeah, that is what that control the systemic vasomotor control. Now in general, there are several factors, but there are sympathetic factors and parasympathetic factors. Both are in act together all the time. So in general, the patient or any normal human beings, is always in a state of partial vasoconstriction. That is the tone of the arterioles or venules. Okay, so now there are two fast acting mechanisms and one slow mechanism. So let us see what are those. So the baroreceptor in aortic arc and the carotid sinus, they act on any changes over seconds. Okay, so vasomotor control over seconds, that act is baroreceptor in aortic arch and carotid sinus. Then over minutes to hours are the left and right atrial stretch receptors. Okay, atrial. So here was aortic arch and carotid sinus. Here we have left and right atrial stretch receptors and cerebral baroreceptors. They act in over minutes to hours. Then we have the RAS, renin angiotensin system, that takes generally hours to days to act. Okay, for this autoregulation. So aortic arch and carotid sinus, what happens is on activation, suppose there is a reduced blood flow or suppose there is a high amount of blood flow. Okay, just keep in mind that we are now discussing normal physiology and not any diseased condition. So suppose there is an increased blood flow, reduced blood flow because of some disease condition. So what happens in general, means we are not going beyond autoregulation now. On activation, suppose there is a low flow or high flow, they get activated, the receptors. So there is, suppose in brain there is BNP or brain natriuretic peptide release, and in cardiac there is ANP release. They affect the atrial tone and renal tubular reabsorption. This rapid response is provided by the autonomic nervous system. So hypotension, suppose there is a fall in BP because of the low flow, so that stimulates the baroreceptor stretch receptors, and that stimulates, after that the brainstem gets stimulated and there is an increasing sympathetic response. So that is vasoconstriction by the norepinephrine release in the in your postsynaptic. Okay, so that causes your vasoconstriction. Now this is up to the capillary doesn't get involved in this. Okay, because the concentration is very low. Now this effect of norepinephrine is directly proportional to the concentration of the receptors. That will again discuss later. So the effect is up to, but not including the pre-capillaries, sphincter capillaries. The capillaries don't get affected by this sympathetic response. It is only up to the arteriole. Okay. So inhibitory signals are also sent, so that reduces the systemic vascular resistance, so that more flow takes place into the organs. Now this cannot be generalizable to all disease states, which I told earlier. Okay. So now then coming to the arterial stretch receptors, that is from minutes to hours. So in atria or the left ventricle and the lung parenchyma, we have some receptors, the stretch receptors. Now this lack of arterial stretch, so means because the flow is low because of hypotension or because of low flow state, it could be because of hypovolemia or could be because of septic shock, there is vasodilation. So there is no more stretch. So this leads to arterial vasoconstriction in animal studies. Okay, so this is the autoregulatory mechanism. Now, activation of stretch receptor, suppose there is a high flow or there is a hypertension, so the stretch receptor is activated and that causes vasodilation and bradycardia. So that becomes your BP4 comes down and brings it back to normal. Okay, so there is vasodilation and bradycardia. Similarly, pulmonary venous congestion leads to activation of juxtapulmonary receptors that induces tachycardia and inflation of lungs that leads to vasodilation. Okay, similar activity everywhere. Suppose the pressure is high, there will be vasodilation and bradycardia to bring it down. Suppose there is low flow, then there will be vasoconstriction to increase the BP and flow. Okay, so the eventual outcome is to maintain the constant perfusion pressure. So this is what is generally autoregulation. Now then there are also chemoreceptors. Chemoreceptors are present in your aortic and carotid bodies. So they again stimulate the sympathetic tone. Suppose there is lack of oxygen or increase of carbon dioxide or increase of acids, acidosis. So they cause increase in vasomotor tone to increase your pressures. So generally they respond to pressure changes also, but they are less responsive than baroreceptors. The chemoreceptors doesn't mean they only have to sense O2, CO2 and H+. Even low flow states can cause stimulation of the chemoreceptors, but they are less responsive than the baroreceptors. So the baroreceptors will get stimulated first because of the flow changes and then the chemoreceptors. Now coming to the role of CNS, so especially in brain, when brain experiences isolated hypoperfusion, maybe due to raised ICP like so. Okay, so the ICP is raised, so less amount of blood is going to go into the brain. The blood flow into the brain is facing resistance because of the increased intracranial pressure. So that causes reduction in blood flow. This reduction in blood flow is the cause of ischemia in the brain tissue. As there is low blood flow, there is a rise in local CO2. Now this local CO2 will stimulate the medullary vasomotor center, which in turn stimulates the PNS, parasympathetic nervous system. So what happens in ICP, which was earlier described as the Cushing strat, this was the theory behind it, that once the medullary vasomotor center is stimulated, so systemic hypertension is because of the sympathetic stimulation, okay, and the bradycardia is because of the parasympathetic output increased, okay. So here the PNS means peripheral nervous system, okay. Once it is increased, so systemic hypertension is because of the sympathetic stimulation and bradycardia is because of the parasympathetic stimulation, okay. So that was the cause of Cushing strat, like in ICP. So that was your hypertension, bradycardia and agonal breaths. So this explains the hypertension and bradycardia. Now coming to perfusion pressure is the pressure that perfuses the organ, okay. So but the central arterial pressure, that is a BP of 120 by 80 or whatever, that is the central arterial pressure, that is not organ perfusion pressure. Organ perfusion pressure is input pressure minus output pressure. Like in your brain, your output pressure will be your ICP and input pressure will be your systolic or your normal BP, blood pressure. So the difference will actually cause the perfusion. Now suppose your output pressure like ICP is high, so the perfusion will be lower, okay. Now coming to in liver, input pressure is lower than the MAP due to high hepatic arterial resistance, okay. So the flow in the liver or the perfusion pressure is 20% lower. Now in heart, what happens? Input pressure is closer to diastolic than to MAP. So that is why the cardiac perfusion takes place during diastole, okay. Now what is critical closing pressure? As I told earlier, that venous pressure if it is high, that will cause a back pressure to organ flow, okay. So the pressure at which this flow closes, that is called the critical closing pressure. It is defined with a resting tone in arterioles and is greater than the venous pressure, okay. So when the flow to the organ ceases, that is called the critical closing pressure. It is not constant and it varies with metabolic activity, okay. Suppose your metabolic activity is low, your critical closing pressure will be higher. So this tightly controls the local blood flow. Suppose there is a fall in BP or increased metabolic activity, so there will be reduced arterial or precapillary tone, which will lead to full dilation, and venous pressure becomes the back pressure, okay. So in brain, the ICP or the venous blood pressure in brain, whichever is higher, is your critical closing pressure. In the left ventricle diastolic pressure or right atrial pressure, whichever is higher, becomes your critical closing pressure. In intra-abdominal organs, your IAP or CVP, whichever is higher. In kidneys, it is the intercapsular pressure, or the IAP or the CVP, whichever is higher, that is your critical closing pressure. So if this determines your perfusion pressure, okay. So in case of brain, ICP; in case of LV, your LV diastolic pressure, RAP, which is higher. In intra-abdominal organs, your IAP or CVP, and in kidneys, these pressures, they will determine your perfusion pressure will be at a higher or lower range, okay. So as these pressures vary from organ to organ, specific target MAP for all may not ensure adequate perfusion to all organs, okay. Now coming to the imbalances, okay, that we face in ICU: disturbance of normal blood pressure autoregulation, okay. So the organ perfusion generally of our body is maintained over a wide range of MAP, okay, but once it goes beyond that, then the autoregulation fails. So the supply of oxygenated blood to the organ depends, as I said, on the organ perfusion pressure rather than the systolic blood pressure itself. Suppose the systolic blood pressure is high, is 160, so we will think it is good perfusion. Suppose the venous back pressure, which we describe critical closing pressure, suppose the like ICP is 150, so there is a perfusion pressure of only 10 difference, so there will be no proper perfusion of the organ, okay. So it depends on organ pressure, perfusion pressure, rather than your arterial blood pressure. Now failure of adaptation, accelerated hypertension or prolonged hypertension, this leads to your organ damage. Now accelerated hypertension, control mechanisms get overwhelmed, that is why we face conditions like PRES, okay, posterior reversible encephalopathy syndrome. Now suppose there is significant hypotension. Now if there is hypotension, there will be local vasodilation, there will be increased organ flow till adequate input pressures. Now inadequate input will lead to failure of baroreceptor augmentation. Suppose the input goes quite low, very low, when the autoregulation fails, so there will be failure of baroreceptor augmentation. Local tissue demands are not met. So what happens then is diversion of blood flow from other other organs. Okay, so as each organ is interdependent on each other, suppose the renal flow gets compromised, so the body will try to divert your hepatic flow or intestinal flow and take it to the kidneys to increase the flow. So that is what is called as our circulatory shock. So the kidneys are already at low flow states, the body tries diverting flow from other organs to that kidney, and so that is circulatory shock. All organs get devoid of your proper flow. That is called circulatory shock. Now, circulatory shock can be due to many reasons. Not only, don't always keep septic shock in mind. It can be because of your hypovolemia state, inadequate volume, okay, vascular obstruction, or like pulmonary embolism, or impaired pump, that is AMI, SOS, or vasoplegia, as in our septic shock. So, condition where baroreceptors are in a state of maximal stimulation, and the sympathetic discharge is the compensation to maintain flow. Okay, alpha receptor is directly proportional to the alpha receptor concentration, as I told earlier. So skin and skeletal tissue have maximum concentration, so the maximum effect will be seen in skin and skeletal tissue. The coronary artery have minimum alpha receptor concentration and brain have none, so it depends on that. So that explains your skin mottling in shock or high doses of norepinephrine. Suppose the dose of norepinephrine is very high, or there is severe shock that the norepinephrine, autoregulatory norepinephrine release is so high that causes severe vasoconstriction in the skin and thus cause to skin mottling. Okay, so our body allows preferential blood flow to critical organ and efficient delivery of oxygen. So delivery of oxygen, if it falls below the critical flow, so it becomes pressure dependent, and that causes ischemia. Now let us see what happens in sepsis. In sepsis, there is, as we know, there is peripheral vasodilation and organ vasodilation. So that is a constant state of vasoplegia, irrespective of your autoregulatory norepinephrine and epinephrine. Okay, so that can be because of either because of your unresponsive receptors, or they require very high doses which we provide from outside like norepinephrine, vasopressin and all, or your local mediators overwhelm. Okay, so once there is vasoplegia, so there is hyperpolarization of vascular smooth muscle, local presence of nitric oxide by inducible NOS or bradykinin, PG or LTs, they also can cause, or alpha receptor downregulation by autodigestion or internalization due to dysfunctional glycocalyx. So these are the causes of your vasoplegia that can be seen in sepsis or septic shock. Now coming to chronic essential hypertension. Here what happens, the autoregulation gets reset. Okay, the flow and pressure relations goes upward and right. So that is why when we have a patient of hypertension, we generally target higher MAP with those patients. Why? Because the hypertensive autoregulatory zone gets shifted to right, as you can see in this diagram. So the blue is your normal autoregulatory zone, but in a patients with essential hypertension, your autoregulatory zone gets diverted to right. So if in these patients you target lower MAP, as in 55, 60, 65, the organs may not get perfused in such patients. So in these patients, you have to target a higher MAP. Okay, so cerebral blood flow regulation has also new set points. So target higher MAP in patients with essential hypertension. Okay, else there is increased risk of stroke, renal injury and myocardial ischemia. There is one study which was published in 2014 in NEGM by USFR. So they were high versus low blood pressure target in patients with septic shock. So basically they had two groups, and their target MAP in one group was lower one, 65 to 75 versus 85 to 95. Eventually, it was seen there was no difference in mortality. However, there was higher incidence of new onset atrial fibrillation in patients with higher MAP target group, in the MAP target of 85 to 95. So it was seen that there was no difference in mortality, but adverse effects were higher. However, in a subgroup of patients in your analysis, post-hoc analysis, it was seen that in patients with essential hypertension, there was higher incidence of renal injury and need of RRT in lower MAP group. Okay, as I said in the previous point, that if we target lower MAP in case of patients of renal hypertension, organ perfusion will be affected because the autoregulatory range has been reset. It has moved. There has been a right shift. Okay, so lower pressures may end up in hypoperfusion and tissue damage. Okay, so it was seen in this study, and it was significant. It was seen in the study that patients with essential hypertension, so if the lower MAP was targeted, there was more incidence of RRT and renal injury, which was clinically significant, statistically also. So clinical implications of this is that exact range of autoregulation cannot be determined. It varies from organ to organ, person to person. A fixed value is not for all organs or not for all person. So the adequacy of MAF can only be gauged or assessed by your organ function. If there is organ failure, that means there is some hypoperfusion in that organ. Okay, so what are the parameters, bedside parameters that can be used as a surrogate for organ perfusion? Those are SVO2 and SCVO2. So these are the normal values. So we see lower values generally in anemia, atrial hypoxemia, or reduced blood flow. So sepsis. In sepsis, what happens? There is always, remember, we have thing is that sepsis is always a high cardiac output state. Okay, there is a hyperdynamic circulation and there is maldistribution of blood that causes organ failure. Okay, the cardiac output is very high, the cardiac output is not low. So that is why we also may get higher values of SVO2, SCVO2 in sepsis patient. We will not get lower values thinking that there will be reduced blood flow. No, it is a high blood flow state. Okay, so this has led to interest in measuring AV gradient of O2 and CO2 in patients of septic shock. So serum lactate, we are commonly using. Your surviving sepsis guidelines also ask to measure serum lactate and monitor that, serial monitoring. They also measure tissue perfusion. But the problem is that beta receptor stimulation, liver failure may also lead to lysin lactate. But nonetheless, it is a good marker and is recommended by the surviving sepsis guidelines. So the take home message is that arterial BP is maintained by multiple systemic and local mechanisms and even some yet not explored. So CNS also plays a great role in maintaining all this, not only your heart. So MAP is maintained by 3 mechanisms: rapid, intermediate, long acting. The local vascular weights regulate perfusion. So till it is not overwhelmed by persistently extreme BP. Okay, so that means auto regulation works only within a certain limit. If it goes below that or above that, it will not fail to act. Okay, sorry, it will fail to act. Okay, so the organ hypoperfusion can be assessed by several surrogate markers as lactate, SVO2, SCO2, AV gradients of O2 and CO2. Okay, so thank you. If you have any questions, you may ask in the comments. I will reply them. I'll be happy to reply. Thank you.